And then Suzanne's going to approach from the dietary perspective. And so we can go ahead and get started. So I was understand we're talking about the GLPs, and that's what everybody has questions about because that's what's being used the most for weight loss right now. Those medications are unique. They first hit the market as agents to utilize for diabetes management, and then we saw the benefits in weight loss. And so 3 companies pursued weight loss indications for their GLP, or there's another class of medications that's called GLP-GIP. So liraglutide was the first one on the market. It came under the market as Victoza for diabetes management, and it is Saxenda is labeled for the weight loss. The difference in it is that we use a higher dose for weight loss with that agent. You can lose around 6 to 8% of your body weight when you use liraglutide. Semaglutide was the second one that came on the market for weight loss. The generic name, or not the generic, but the brand names for diabetes management are Ozempic, or the oral formulation of that is Rybelsus. And then it has a weight loss drug indication, which is Wegovy. And again, that uses a higher dose than what you would use for management of diabetes. And then the one that's most recently on the market is tirzepatide. The Mounjaro is the diabetes name for that product. And then the Zepbound is the weight loss drug name. And the difference between semaglutide's weight loss is around 12 to 15%. So you see we kind of doubled from liraglutide with that. And then tirzepatide is anywhere between 11 to 21%. So again, you get more weight loss with tirzepatide than you get with using semaglutide. The challenge with using these agents is that it can cause a lot of GI issues. Nausea is one of the big ones, and vomiting. And these can get better with time, but in some patients, they don't get better with time, especially if there's gastric slowing already. So patients that have diabetes may not ever improve in regards to the nausea and the vomiting that accompany it. You also can get constipation as well as diarrhea, and that seems like you shouldn't be able to have both of those, but that's because of how the drug works that you actually can. It slows down gut motility, and that's the thought behind constipation. But then if things start moving, then we have some diarrhea with it as well. These agents should not be used in patients who have a history of pancreatitis, who have gastroparesis. If you've got a history of thyroid cancer, I would be really cautious with using these agents. If there is GI disease, such as ulcerative colitis or Crohn's disease, I would be very hesitant to use these agents. And then there's some newer data that's coming out that suggests these agents may be associated with suicidality. So if someone has a history of suicide, it's not contraindicated, but it's being suggested that we should use those with caution. And so I would agree with being pretty cautious if there's that history that's present in a patient. These agents, if you use them for weight loss, you're going to have to continue to use them for weight loss. What the studies show is that if you lose weight on them and then you discontinue them, you go back to where your weight was prior, especially if you've not implemented lifestyle modifications such as diet and exercise. And so that's really important to keep in mind, that it would be a long-term commitment when you use these. They should be in conjunction with exercise and dietary changes. That's so important to have that in conjunction. The other thing to think about is the availability of these agents and the cost of these agents. Insurance is not always covering these agents for weight loss. And if you pay cash price for the prescription branded products, and there's no generics available right now, they're between $1,200 to $1,600 a month cash price. So they're incredibly expensive to pay out of pocket for. There's a lot of shortages for these products because they are in such high demand. And that can really limit availability. And I think that's why sometimes people are turning to compounded products. The FDA says that they'll allow compounding if the commercial product is in shortage, and most of these products have some shortage, but they should still be meeting state and federal laws. The challenge is every state has different laws. So Alabama's is pretty strict, and you have to use the commercial product that's available from the manufacturer if you're compounding in Alabama. The challenge that we see in Alabama is we have providers who are getting that product from out of states or out of state in states that are not as strict as Alabama. And so what you're seeing on the market a lot of times, especially if you don't have to have a prescription or you're using somebody that's mail order and it's not a credible pharmacy, is they're using salt formulations of semaglutide or tirzepatide. And those products are actually intended for for research use purposes. They're not regulated. Their products are not as pure as what we would find in commercially available products. And so Alabama says you can't dispense those from a licensed pharmacy or by a licensed pharmacist in the state of Alabama. But other states don't have that rule. The other thing that we're finding sometimes in compounded products is there's other ingredients because they're not using purified or regulated ingredients. They may have contaminants that are in there. And so that's of concern as well. We don't know how stable they are shelf life wise because, again, it's not regulated in compounding pharmacies. And they're also using and developing different formulations. So currently, when you use liraglutide, semaglutide, or tirzepatide, those are all injectable weight loss agents. But we have pharmacies that are compounding or someone's compounding it into sublingual drops, into suspensions, into oral disintegrating tablets, into nasal sprays, and none of that has been studied for use in patients for weight loss or diabetes. And so that's of concern that we don't know if you're getting the actual product, if you're getting more than you're supposed to get, if you're actually absorbing what's being given to you. And so I would just, if you're thinking of using a compounded product, I would just make sure that you have a trusted pharmacy that you're getting it from, that pharmacy is licensed in the state of Alabama, because I know you're going to get quality product if it's in the state of Alabama because of our statutes and what we regulate in our state, that the pharmacist is readily available or their staff are readily available to get that from. And they're not making false claims. If somebody's pushing a lot of claims for compounded products, they really can't make those claims because they've not been studied the way that the commercial products are. And again, there's a vast price difference between the compounded products and the branded products that you buy that's been approved and gone under rigorous testing by the FDA. So I would just be very cautious with compounding and using those compounded products. I'm going to stop right there, and if you've got questions, you can put it in the chat. Long-term effects from using these weight loss agents for an extended period of time. That's an excellent question. We have some longer-term data with using these products in diabetes at lower doses than what are used for weight loss. When I say longer term, we have several years of data with at least semaglutide and liraglutide. Tirzepatide is the newest to the market, and we don't have that long-term data with it yet. We would love more. And I think that's probably my biggest concern with using these agents for weight loss is we really do not know what the long-term effects. My concern, knowing how the drugs work, would be how it's going to impact gut motility. And how, I'm afraid your stomach's going to not move. If we continue to slow it down, it's at some point those muscles are weakened and they're not going to continue to move food through. That's my biggest concern right now, based on what I understand about the drug and how they're working for weight loss. But we don't know how that's going to work long term. And again, if you have to use these drugs long term to maintain the weight loss, then that is going to be a longer term. Somebody asked the question, are these used for life? You wouldn't have to. If you can implement lifestyle modifications to help with weight loss and you use this as a jump start or a kick start, then you could potentially come off of these agents with lifestyle modifications. But if you use this as the only mechanism for weight loss, when you stop the drug, you will gain the weight back. And even if you stop the drug implementing other weight loss things such as diet and exercise, you could see a bump in your weight. But again, if you've implemented healthy lifestyle things, it would mitigate that weight regained because you're losing weight a healthy way. Long-term implications for use of Trulicity. So Trulicity is only indicated for diabetes. It has not been studied for weight loss. It works the same way that semaglutide and liraglutide do. So they would have weight loss. It should have weight loss associated with it, but it has not been studied where I could give you a percentage weight loss that you would get with Trulicity. You're going to have a hard time getting Trulicity covered by an insurance plan for weight loss. If you don't have a diagnosis of diabetes, I don't think it will get covered by an insurance plan because it's indicated for patients with diabetes. Other questions? Do these drugs cause lean muscle mass loss? They will cause you to lose lean muscle mass, absolutely. And Suzanne's going to address that a little bit from a lifestyle standpoint, but they do cause lean muscle mass loss. And that's a big factor. So if you're going to use one of these, you want to work on the dietary things that Suzanne's going to talk with you about, but you also want to be very intentional with using exercise options that will help you build muscle. And maintain or prevent loss, as much loss of muscle as you can. So that's weight-bearing exercises, resistance exercises, and weight training. Those things can help in addition to the things that Suzanne's going to talk about too. But you do lose significant muscle mass. And as we age, we're going to lose muscle mass anyway. So that's something just to keep in mind. And this compounds on top of the age-related weight muscle mass that we lose. Does your body respond to the medication differently depending on where you inject it? Great question. No, there's no data that shows there's any difference in where you would inject. So if you look at the package inserts for these drugs, it's going to tell you that you can inject on your abdomen, in your fatty part of your thigh, and the fatty part of your arm on the back of it. And those are all acceptable places, but there's no data that shows there's any difference in where you would absorb that from. I like using the abdomen the best for most patients. That's a more consistent because sometimes we tend to get in muscle if we go in the thigh or the arm. But if you're injecting in a non-muscle area, it should be the same absorption regardless of where you put it. All right, I'm going to let Suzanne talk, and y'all can continue to put questions in, and we will answer those as you put those in.
Okay, thank you so much, Dr. Carroll. Miranda, can you hear me fine? We're good? Okay.
Yes,
okay, fantastic. Thank you. Great questions so far. Obviously, these drugs have just, I mean, it's been huge how it's affected certainly my practice as a registered dietitian. And what we wanted to discuss today, or the information to give you, is if you're using them, here are several factors to keep in mind. And really, these are good ideas for anyone, whether you're using the medications or not. So there's three primary things to combat the GI symptoms that Dr. Carroll talked about. And I'll just list them out and then we'll discuss each one. One, you've got to get enough lean protein. As Stephen in the chat, as you questioned, do these drugs cause lean muscle mass loss? Absolutely. And that happens with weight loss, period. Okay. It's more pronounced with these drugs. So we'll talk more about that. And I have some handouts for you that Miranda's going to share in just a little bit. So definitely eating plenty of lean protein, increasing high fiber foods. And I've got some ideas that we'll share with you. But because the GI system is not moving as fast as it normally does, we've got to get fiber in you in order to kind of help move things along. Otherwise, the constipation becomes a major concern. And whenever we increase fiber, we've got to increase fluid intake, okay, because they work together. If you think about if you've ever made a bowl of oatmeal, for example, those oats are just, they're dry and you can sift them, but you add water or milk and it forms a gel. And that's what, if we can get some high fiber foods in, then that'll help move things along in the GI tract. So increasing protein, increasing fiber, and then fluid to go along with it. So now let's talk about the ways to do that. And then we'll also talk about just some things that I know I've seen with patients, I know Dr. Carroll has seen with patients, just to be aware of. So definitely increasing lean protein. I would choose at my meals and snacks work a protein choice in. And I've got lists for breakfast ideas as well as snacks that Miranda's uploading right now. And the increasing the lean protein, which we try to do just for anyone, particularly with aging, because we know that we lose lean muscle mass naturally as we age. Women kind of, I'll ask women who come to meet with me in my clinic, did you start to notice that back of the arm started to not be as muscular as you aged? And we all typically realize that, but these drugs, because they do promote in most people greater weight loss, that's happening more rapidly. So, it's not just the chicken, the lean beef, lean pork. Eggs are fantastic. I love, and you can find a recipe for roasted chickpeas are great because it gives you protein and fiber at the same time. There's a lot of products on the market that I have listed on those handouts. The Kodiak brand, for example, which is readily available at most all grocery stores. They have high protein muffin mixes, oatmeal mixes, so a variety of things out there. Eggs are fantastic. Eggs are almost perfect protein. And so not just hard-boiled eggs, but there's also commercial products in the breakfast food section of the grocery store. One that's been on the market for several years that I love is the Just Crack an Egg, where you literally just crack an egg in a cup, microwave it for 90 seconds, and you have breakfast. So definitely got to get increase the lean protein. I would make that at my meals the first thing you eat, because what patients have told me, whether they're managing diabetes or they're just taking the drug, is that they get full so quickly that they don't get enough in. Okay. And so not only are we worried about the loss of lean muscle mass, we're also worried about the fact that you're not getting the nutrients you need because you literally can't take enough in. And I'll, as an aside there, Stephen, your question, please discuss how these drugs pair with different diets. My chief interest is the vegetarian diet, eggs and dairy only, lacto-ovo, vegetarian. Absolutely. You can definitely, eggs, the nice thing about eggs and dairy is it's compact. I've got a recipe for a cottage cheese peanut butter dip that one of my students developed and swears by it. And that is the cottage cheese is a perfect source of protein. I would encourage you use the small curd, and then she's mixed it with some peanut butter powder, and fantastic snack that is rich in protein but meets the need for somebody with a lacto-ovo, meaning they drink milk and eat eggs in their diet. So absolutely. So take a look at those as Miranda's uploading them. So get the protein in, make that the first thing that you have. Okay. So that we're getting that in. And then with high fiber, look to things that are also kind of high fiber foods are great to work in for snacks. For example, bananas, any kind of fruit. Oats are fantastic. I've got a recipe that Miranda will upload for a peanut butter oat recipe with some mini chocolate chips. You can keep those in there or take them out. It's just got a little honey in it to sweeten it. But those are a compact snack or could be a breakfast option. Okay. So, but the fiber is going to help move things through. Okay. Now, again, the fluid we've got to increase, and that doesn't necessarily have to be just plain water. I know I've certainly over the years have talked with a lot of people who said, I just don't like the taste of plain water, or you may be taking another medication that alters your taste perception. We can certainly flavor waters with lemon, orange, lime, or you can use flavor packets. Those are fantastic. One thing you can also do is just flavor, just take good old fashioned ice cube trays and pour those flavored waters in there. And then you kind of have a nice effect without having to think about it. So, but we've got to get that, the fluid and the fiber together, because if you just have fiber alone, it kind of gets stuck, okay, in the GI tract. Now, some things to keep in mind that I know I have seen some of the nurses, the physicians that we work with, some things that we've seen. I had one patient who the Mounjaro beautifully controlled her diabetes, But as the dose was increased, she actually started developing low blood sugar, hypoglycemia, okay, to the point it necessitated a trip to the emergency room. So if you are when you're taking those drugs, if you want to, or if your physician increases the dose, please be aware of what could happen. Okay. And I know we've seen that where some people have increased the dose on their own without their physician's oversight, and they ran into a problem. Okay. Now, one thing you can do that's has just come out at the end of summer and is more are coming out is what are called continuous glucose monitors, or CGMs, which have typically been used by people who have insulin dependent diabetes. Those are coming out on the market for over the counter use. And this is brand new within the past month. Okay. And those are ways to monitor your blood sugar to kind of see where it's running, so that if you're, using some of these products, how is it affecting your blood sugar? Because even if you don't have diabetes, you could have lowered blood sugar that leads to some hypoglycemic episodes. And it says one of the staff that I work with, she said, I took Ozempic, had never taken it before, and got up to take care of a patient and just dropped to the floor. Okay? So please be aware of that. Also, as the dosage can be increased, you may see more GI side effects. And so, having that conversation with a physician about, do I need to back off of the dose? That's something to look at as well. And I know I've worked with patients to take a look at with the nausea that they may be experiencing, how can we mitigate that? Okay. So increasing the fluid, maybe doing, again, compact foods, or just looking at, are there foods that you can't tolerate? And that varies from person to person. You may have liked spicy food 2 months ago, but now you're taking the medication and it's causing a nausea reaction. And so we just need to work with that. Okay. And please know that at University Medical Center, we are available to meet with the campus community. For anybody on this call who may be a graduate student or pursuing graduate studies, there is a dietitian in the Student Health Center as well. Okay. So please know that we're here to kind of help you with those, because, as Dr. Carroll said, they've been out for a while, but we're just really seeing the boom in the use of them. And Lakeisha Martin says, I'm happy about the blood sugar monitors. Yeah. And a lot of people are interested just to see how different foods affect them. Okay. And Stephen, you're asking, and this actually just hit the news, I think last week, I sent it to Dr. Carroll. How should the intake of prebiotics and probiotics be adjusted when using these drugs? Great question. So pre and probiotics actually help with gut function. What I would advise you, and this is with any over-the-counter supplement, is use a mainstream brand. Please don't use some of these really expensive offshoots. I know my social media feed, and one of our nurses, Nat and I were talking this morning, she said, once you've sent that to me, now my feed is filling up with all these products. And I would tell you, don't give anyone that money. Just go stick with the mainstream brand for your pre and probiotics, because more expensive is not necessarily better. Okay. Dr. Carroll, would you like to weigh in on that point too?
No, I would just agree. Mainstream brand that's trusted, that you can get in a GNC or in a community pharmacy like Walgreens, Walmart, CVS. Not buying it offline, online, that's really pricey because they're not regulated. So you really don't know what you're getting if you're paying, markedly more. Is the gut less active and are there side effects related to acid reflux? You could have more reflux associated with it, especially if you have things not moving through the stomach.
And on that note, I would tell you, Stephen, that's a great question, and I have to tell people this pretty regularly, is never underestimate the effect of gravity, of literally being upright helps things to move. And so that's where being more physically active, as Dr. Carroll was mentioning, not just the resistance training, but just moving more, walking more, and take a look in the building you work in, what's around you. You know, are you somewhere where you can take the stairs, or is that safe? You know, if knees and hips, etc., allow for that. But just being upright makes a difference in helping things move through. Okay. Sonia, you've asked, how can you get a CGM if you don't have type 1 diabetes? The Dexcom company just last month announced that these are coming out over the counter. And then Abbott Laboratories is also coming out with one. I would check with your local pharmacy. The initial pricing that we've seen is for a one-time purchase. It's right around $99 for a subscription. It was around $89 for the Dexcom brand. It is interesting, but what I would encourage you is that if you do choose to do that, you may just want to wear it for a month. Usually those sensors are good for 2 weeks at a time. The ones coming out may be a little bit longer, but just kind of see how foods affect you, because it's really interesting when somebody wears a continuous glucose monitor, you're getting so much information 24/7 that it can be a little bit of information overload. And particularly for family members who are, you know, who may be connected to your continuous glucose monitor, and they're concerned about you, but they may be overly concerned, and you kind of start to get a little bit of information fatigue with that. Let's see, Meredith, you said, I have type 2 diabetes and just got denied with our insurance for a CGM. Typically for insurance coverage, those have been for individuals who are insulin dependent. So, and I will tell you, I've had this conversation with one of the representatives for a company that makes blood sugar meters, continuous glucose monitors, is that when people are on these drugs who do have diabetes, when their blood sugar starts to come down and maybe they come up, like they're no longer on insulin, they can't get those monitors anymore. So there's pros and cons, but do take a look for those that are coming out over the counter. Some additional questions.
I did see a question someone asked earlier, is will these drugs cause you to develop diabetes? Did we get that one already, that question?
We have not answered that one yet, but they are not, we do not know of anything that would cause diabetes. If anything, they would help reduce the risk of diabetes, but there's no data that shows that. So I can't say that with confidence, but we use them to treat blood sugars. So they're going to lower the risk of having hyperglycemia in patients.
I think I would just encourage everyone who's on the call, and we say this with over-the-counter supplements, as I mentioned earlier about pre and probiotics. Just because a little of something is good does not mean a lot is better. I've known of a couple of situations in which individuals got the drugs, got the compounded type, so they didn't necessarily have diabetes, and they increased the dosage themselves, or they're taking another person's medication, and have gotten into some trouble. So just remember that just because a little is good, a lot is not necessarily better. And that's, as Dr. Carroll said, working with a physician or someone who has some oversight is critical, in my opinion, with some of the things I've seen. Let's see.
So Leslie, your question is if someone's better suited for these interventions, meaning someone who wants to lose 10 to 20 pounds versus someone who wants to lose 50 plus pounds. Again, I think this is where you have a conversation with your healthcare provider about what your goals are and the best ways to meet that. 10 pounds, I think, is accomplishable with lifestyle modifications in a patient most of the time. 20 pounds, again, it depends on what your baseline weight is and do you need to lose 20 pounds versus somebody who's 50 pounds or more. Again, your healthcare provider knows your comorbidities or your medical problems that are going on. They know your other medications that you're taking, and you can talk about healthy weight loss goals with them. Sometimes we want a quick fix. Healthy weight loss is a half a pound to a pound a week. Patients sometimes push back on me when I say that. If you're doing lifestyle modifications on that, so it's a slow and steady wins the race kind of picture. So there are times that these agents would be appropriate, but then I can think of times that using these agents would not be appropriate, even if you needed to lose 50 plus pounds, because they would be contraindicated or cause more problems. So again, I think I strongly encourage conversations with your healthcare provider to figure out what are realistic goals and what are the best ways to accomplish that. Because if you take these agents and you really don't have a plan for exercise or diet, it's just not as effective as it could be if you implement the lifestyle things with it.
And yeah, on Dr. Carroll's note, I know I've had patients, or we have internally, who have had gastric sleeve or have a history of having the Roux-en-Y or gastric bypass. And typically physicians do not want to give these drugs to people who've had bariatric surgery because the GI system's already been altered. So just as a note on, who might not be a good candidate for that.
On the note about Blue Cross Blue Shield covering obesity meds, so usually private insurance companies follow what the U.S. government does, and Medicare has a statute that covers no weight loss medications. So I'm not surprised that most private insurance companies are not covering weight loss medications because, again, they follow whatever the federal government does for Medicare by and large. So again, you're going to pay out-of-pocket cash for a lot of the agents if you don't have an indication. And you're right, prediabetes doesn't count for use of these drugs because they haven't been studied in prediabetes.
We got a question in the Q&A. Is there concern for someone who has had their gallbladder removed?
If the gallbladder's been removed, these drugs are not contraindicated. If you have a history of gallstones, though, there's a potential that these drugs could make that worse. Stephen's question is alternative pharmaceutical interventions. If you're not, so it's going to be all weight loss drugs, not just the GLPs that we're talking about today. All weight loss drugs are not covered by insurance companies because federal government covers none. Even the cheapest one, they do not cover. That's a statute because it's an old statute and they're trying to make changes to the statute, but I don't know if it'll get passed because it would, the reason they're holding out on passing it is they think it would bust the Medicare budget if those were now included because of the number of patients and the cost of these agents that would potentially use the drugs.
Oh, okay. Leslie, your question, have I seen anyone start these drugs and develop food aversions or allergies? That's a very good question. We were discussing that in clinic this morning. We have seen patients who had nausea, vomiting, constipation to the point that they just couldn't take them. Now, a specific food aversion, as I mentioned earlier, I've had people who previously loved a certain food and now it triggers a nausea response. Okay. So that I've seen, but we have seen some people who just can't tolerate them. For the individual that I mentioned earlier, that when the dose was upped to help lower her blood sugar even more, it actually caused a hypoglycemic episode. And so they're looking at that dose may not be appropriate for her. Okay. But I will tell you, food aversions and allergies are interesting. I've seen individuals over the going on 10 years that I've been here that all of a sudden they can say that they developed a food aversion and just couldn't tolerate a favorite food anymore. So anything can happen at any time. I think for any of us on the call, once you get to a certain age, you kind of realize things just happen. Things just happen. So So, Stephen.
I don't know, Stephen, about any
Yeah.
existing allergies unless you've had a reaction to one of these agents in the class. Certain medications that work better for other people, someone to respond well to Ozempic but show positive results to Mounjaro. There's not anything that suggests there's patient differentiation. There is differentiation with the drugs. So again, Mounjaro, based on the research data, is going to give you the highest percentage of weight loss. Compared to semaglutide or liraglutide. Different toleration of the drug may be different. We don't have head-to-heads where you could say one's better tolerated than another. The percentages are comparable when you look at the studies. So I don't know that I would say if you don't respond to Ozempic, you should switch to something else. It's just you're going to get more weight loss with like a Mounjaro or a Zepbound based on the data and how it works. But again, semaglutide is better than liraglutide because you kind of double each time you change. Not quite double with semaglutide to Mounjaro, but there is an increase there.
And Leslie, would you recommend working with a nutritionist? Absolutely, and that's what I've helped people do. Is if you have the nausea, if I have somebody who says, I just stop eating, I just don't feel like taking another bite, then we've got to maximize what you can get in. And because I don't want somebody who's not only losing lean muscle mass, but also becoming malnourished because they're not taking in enough. And again, we know that with aging, we naturally lose lean muscle mass, and that gets replaced with fat. And while the number on the scale may look the same, the quality of the composition of the body is not the same. And that puts us at risk. I'm always concerned about falls with people becoming, they literally don't have the strength that they once did because of fall. And it could be something as simple as a fall in your house, at work. If you hit your head, if you, fracture a hip, then we have a whole different series of problems. So while that takes some time to develop, that is a concern. And because of the more rapid weight loss for most people on these drugs, that's a concern. I had somebody not long ago that was in her 70s and taking the drug. And that was a great concern for me because she's already at risk for losing a lot of muscle mass and at risk for falls just by virtue of age. And then those drugs on top of it were a greater concern. So yes, and Leslie, as I said, I'm at University Medical Center. My counterpart at Student Health Center is Sherry Simpson. And she doesn't just see undergraduates, she sees graduate students, doctoral students, et cetera. So just as a note there. And then we do have a dietitian who is in kind of student life on campus, but does programming that's open to everyone, and that's Sheena Gregg. Okay.
The question on there's supplements that must be taken with these drugs, or is it case by case? I'd recommend a multivitamin, especially if you're not getting in a well-balanced diet. But if you're getting in a very well-balanced diet, you might not need a multivitamin. The concern probably is these drugs don't block absorption of nutrition, but it's like Suzanne's talked about, like you just may not take in enough or the right kinds of foods to help with making sure you don't have nutritional deficiencies. Magnesium supplements, again, if you have a well-balanced diet, then you shouldn't need a magnesium supplement. I usually recommend magnesium oxide if you're using a mag supplement, but we're usually using that for muscle cramps more than anything. Again, if you take a multivitamin, there would be adequate magnesium in that without having to do a mag supplement separately.
And again, on that note, as we said earlier, stick with your mainstream supplements, because again, just because something's more expensive doesn't mean it's better.
Sonia, usually 200 milligrams on magnesium oxide.
Mm-hmm. Yeah. Yes, Susan, that your spouse's insurance with Viva UAB. And I've had the rep for Wegovy tell me that the federal government was covering it for some employees, but I haven't substantiated that. So, always check with your specific insurance plan. And of course, then, I think we'll all be curious to see what happens long term. I mean, I will remember, as I know Dr. Carroll does, when bariatric surgery first really took off in the early 2000s, and the cost was considerable, and that's come down significantly. So it'll be curious to see what happens. And I think that we're also curious as to long term, what will happen with some of the side effects of these drugs. As Dr. Carroll said, are those nerve endings in the stomach going to wake back up?
I think those are all the questions. We've had a good amount today. So thank you for presenting on this topic. It's very informational.
Yeah. And just as a final note, Miranda, since we had a question about making an appointment, an employee can stop by University Medical Center or just contact the front and can schedule an appointment. So just FYI on that.
Okay, perfect. All right, we will let y'all get back to your day. Thank you again.
Hi, thank y'all.